Well, thank you so much. It really is a pleasure for me to be with everybody and to be able to reconnect with my friends from Latin America is really extraordinarily joyful for me. I appreciate Paula's very nice introduction. I do, there is a little bit of a change in my career. The last 10 years, I have partnered with Hawes and we have pioneered a new way of doing endoscopic ultrasound. It's a situation where we have created a center for advanced endoscopy. So we have built a unit that is occupied only by a group of therapeutic endoscopy physicians. And then we have our own technicians and our own nurses into this cohesive unit. I believe that this is the best way to deliver therapeutic endoscopy. But Dr. Veredarajulu and myself have left the Florida hospital system, what is now called Advent Health System, and we've joined another large healthcare system in the Orlando area called Orlando Health. And we are recreating this advanced endoscopy unit that will be open in January of 2022. And so when COVID goes away, I would like to extend an invitation to any of you to come visit our center in Orlando Health in Orlando, as I think that we have very many good things to offer. So I will now go forward with my talk as I think we want to stick within the time limits. So I'm going to be talking about cystic neoplasms and how to manage them. And these are my disclosures. I am a consultant for Olympus, but I do not think that it affects my presentation. The prevalence of asymptomatic pancreatic cysts is significant. In this trial, it was 2.4%. In this trial in Europe done with screening MRI, it was 2.6%. But we must be cognizant of the fact that it increases with age to the point where almost 9% of patients between the ages of 80 and 89 will in fact have neoplastic pancreatic cysts. So this is a significant health issue. Are they important? Are incidental cysts important? Well, they are, because in this CT study, you can see that 60% of the cysts detected on CT in asymptomatic patients were in fact neoplastic and had a malignant or malignant potential. So these are important. They cannot be ignored, particularly when they're picked up incidentally. You all probably know that there are several types: serous-cystadenoma, mucinous cystic neoplasm, and then the category of intraductal papillary mucinous neoplasms, and then solid pseudopapillary neoplasms. There are others, but for the purposes of this talk, these are the ones that are most prevalent. Imaging is very, very important, and I've simplified the imaging for pancreatic cysts. And I think the general utility for CT scan is primarily in detection. Once we detect a neoplastic pancreatic cyst, then we tend to use MRI now for surveillance. And then if there is a worrisome feature or a high-risk stigmata, we will then typically use EUS as a more refined and more definitive way to evaluate these cysts. So this is sort of a simplified way of looking at imaging. I say this because imaging, in fact, is not very good. And I show you here 4 different cysts. I would ask all of you to sort of determine for your own what you think the nature of these cysts are. And in fact, this is what they were. So upper left was a mucinous cystic neoplasm. The upper right ended up being a serous cystadenoma. The lower left was a pseudocyst, and the one on the lower right was a pseudopapillary tumor. I don't know how many of you got 100% on this, but I suspect that probably few people were able to do that based on a static CT image. Imaging morphology by EUS. I think for those of us who are EUS enthusiasts, we thought that we were fantastic at differentiating the different types of neoplastic cysts. And initial studies suggested that we were really, really good at it. However, inter-observer agreement studies have shown only fair inter-observer agreement, and the best was for serous cystadenoma, for serous cystic neoplasms. So these are sort of microcystic and probably are the easiest of all of them to differentiate, and yet the inter-observer variability was only fair. The accuracy was 51% for diagnosing a cyst correctly. So almost like tossing a coin, almost. So the message to everybody is that imaging, although it's critical, it's a foundation of what we do, it in fact is not sufficient with great accuracy determining the nature of the cyst. And of course, the nature of the cyst determines how we manage it. So along about, in the late 1990s and early, I guess 2000s, Bill Brugge came along and thought that EUS-guided cyst fluid analysis would in fact help us to make this differentiation. And we've come a long way in this evaluation. Initially, our analysis was based primarily on CEA, although when we would aspirate a cyst, we would send it for CEA, amylase, a mucin evaluation, and cytology. And the CEA was primarily to decide mucinous versus non-mucinous. The amylase was purported to be helpful in determining duct communication, but several studies have suggested that that in fact is not the case. We used viscosity to see as another test to see whether it was mucinous or non-mucinous. And then finally, cytology was used to hopefully differentiate a benign from a malignant. But in fact, none of this has held true very much. This is the CEA and looking at the sensitivity and specificity for whether or not it was determined to be a mucinous lesion. And you can see here that as the CEA goes up, the sensitivity goes up. But as the CEA goes up, the specificity, the sensitivity goes down as the CEA goes up and the specificity goes up. So the bottom line is that you've got a lot of patients with low CEA who in fact have mucinous cysts, and you have some who have very high CEAs, but in fact it's non-mucinous. So at least in our practice, aspiration of cysts has diminished significantly. This is another problem. This is a study out of Amsterdam, the really good group in Amsterdam looking at cyst fluid analysis, but they took consecutive patients. So these weren't cherry-picked patients, but they were 143 with indeterminate pancreatic cysts. They sent the fluid for the things that we talked about earlier. They were successful 90% of the time to get some fluid with the distance between the transducer and the cyst, or the cyst being too small, being the reason that it was only 90%. But you can look here that you get cellularity only on 30% of the specimens, and then there was sufficient fluid analysis only for 50% of the patients. So, and there were complications of 2.4%. So in fact, a lot of times you don't get any cellularity, and a lot of times you don't get sufficient fluid to make the analysis. again, it's a problem with cyst fluid analysis. I'll go through this quickly. These are EUS pictures of cysts up above. This is the MRI of the cyst. It's sort of, there's several compartments within it. We aspirated this twice. The CEO was low on both of the aspirates. The amylase was sort of high on the first one and medium on the second one. There were no cells on either aspirate. And on the extracellular mucin stain, it was positive. So we've got a mucin stain positive, a CEA that's low, no cells to help us. So we're in a little bit of a quandary as to the exact nature of this cyst. A second one, a unilocular cyst. So you would think it would be mucinous, but the CEA was quite low. However, the mucin stain was positive. Cytology was unhelpful. So again, a unilocular cyst in which cyst aspirate did not give us a definitive diagnosis. There are multiple techniques that are coming to bear on with cyst fluid analysis. So we have imaging, of course. We can do cytology. We're now increasingly doing tumor markers. We can do cyst fluid genetics. And some people are doing duodenal juice analysis to try to figure out what's going on. We can also go for tissue, and that can be done by a cytology brush, or what I think has the most potential right now are mini forceps. You can use confocal laser endomicroscopy or cystoscopy using a small bare fiber can be used. So there is progress being made. But as some of these methods are being tested, they are more invasive, and therefore complications will increase. I think my conclusion on all this is that imaging, cytology, and CEA are in fact limited. If you take an individual, it's limited information. Genetics and clinical features will improve the diagnosis and risk stratification. Brushings are limited, and whether or not CLE, biopsies, or cytoscopy will be more beneficial, I think, to my estimation, requires further study. If we move to the management now, there are basically only three things that you can do with a incidental neoplastic cyst. You can undergo surveillance by whatever method is appropriate. You can send that patient to surgery. Maybe, at least in the future, there may be an endoscopic way to treat it. But in fact, today, it basically boils down pretty much to either surveillance or surgery. That's the only two options for managing these cysts. To try to help us determine whether or not we should do surveillance or whether or not we should do surgery, there are guidelines that have come out. The Fukuoka guidelines have been published. The European guidelines and the AGA guidelines are the three most utilized and cited. There may be guidelines for Latin America. I'm not aware of those, but there may be guidelines that are specific to Latin American patients. In terms of surveillance recommendations, the AGA is particular in its very heavy weight on MRI. So their primary mechanism recommendation for surveillance is with MRI. If there are no concerning features on the EUS, then they recommend an MRI at 1 year. And if there's no change, then every 2 years. And then the big one that the AGA put out there is that if you continue surveillance for 5 years and there's no change and the patient is not a surgical candidate, then you ought to just let that patient go. This is a little of a busy slide, and I apologize for that, but these are the Fukuoka guidelines. For me personally, this is the guideline that I tend to follow, and the important parts of the Fukuoka guidelines are that they break it down into what they call high-risk stigmata. So this will be outlined in another slide, but they divide high-risk stigmata. And if you have a high-risk stigmata, then those patients should be looked at carefully for surgery. If there are no high-risk stigmata, then you survey those patients and you look for what are called worrisome features. And again, I will go over this in a different slide with bigger font, but we look for worrisome features. And then the final part of this is that your surveillance depends on the size of the cyst. And their big thing is that if the cyst is greater than 3 centimeters, that is in fact a worrisome feature, and you should look at those patients carefully and at least consider the possibility of surgery if the cyst is greater than 3 centimeters. The big deal about this is that if you in fact send a patient for surgery that has a high-risk stigmata, if the cyst is in fact benign, then several studies have shown that the outcome is really, really good. However, if you wait and you miss that opportunity, so to speak, and that patient goes from a non-cancer to cancer, then if you operate on already a degenerated lesion that's become cancer, then the surgical results go way down. So that's the key here for finding these people before they become cancer. Most of what I see is a branch type IPM, but this is a slide showing the malignant potential for the various types of cysts, and you can see that the range is quite variable. That's one of the problems that we have. We just don't have oftentimes enough information about the natural history of these to be able to manage them more accurately. If you look at the surgical recommendations according to the 3 guidelines that I showed you, if it's a mucinous cystic neoplasm, all guidelines recommend that you resect it. This occurs almost uniformly in young females and is present in the tail of the pancreas. And so even if there's no malignant signs of malignancy, the recommendation is to resect these. If it's a pseudo papillary neoplasm, then most guidelines, at least the European, the AGA, recommend resection. If it's a main duct IPMN, these patients have a high risk of conversion, and so at least 2 of the 3 guidelines recommend it. If it's a mixed type, then it depends on whether or not there are signs of malignancy. So these are the high-risk stigmata and worrisome features in the Fukuoka guidelines. And again, for me, if there's obstructive jaundice, an enhancing solid component, and the main duct gets greater than 10 centimeters, then I tend to refer those patients for surgery. For all of these worrisome features, it's a little bit of a gray zone for me. I don't reflexly send all patients to surgery with a 3 centimeter cyst, but if you have 2 or more of these worrisome features, then it's certainly something to consider, at least having them evaluated by a competent, experienced pancreatic surgeon. The European guidelines have a little bit of a different look to them. Mural nodules are important in everybody's book. A dilated main pancreatic duct is again a worrisome issue for all of the guidelines. The European guidelines put in this idea of growth rate. So if you follow a patient, you're surveying them and it's growing rapidly, they consider that a worrisome sign. If the patient has symptoms, particularly if they have pancreatitis, then those patients should be considered for surgery. An increased CA19-9 or cyst greater than 4 centimeters is what the Europeans look for when they're referring patients to surgery. And the AGA has cysts greater than 3 centimeters, an associated solid component, and a dilated main pancreatic duct. So again, specifically with side branch IPMN, these are the issues that worry the Fukuoka guideline people. These are the things that worry the European guideline people, and these are what worry the AGA people. And so you have to sort of amalgamate this for simplicity's sake. Maybe you want to follow one of these particular guidelines, but these are the features that worry everybody, and particularly mural nodules. Enhancing mural nodules is one of the most common. So when you use these guidelines, does that really help you? Do you make good decisions with patients? So this is, again, a study coming out of the Netherlands, looking at surgical outcomes, comparing the 3 guidelines. 115 patients undergoing surgery who had high-risk cysts. The preoperative diagnosis was correct 72% of the time. So 3 out of 4 patients had a correct diagnosis going into surgery. The diagnosis was benign from malignant. 86% of the time they were accurate, saying it's benign, but it could be worrisome for malignant transformation. And some of the time they called it frankly malignant. So they were correct 86% of the time. And the surgery they thought was justified if there was evidence of malignancy, evidence of high-grade dysplasia, solid pseudopapillary neoplasm, or neuroendocrine tumor. Any of those, they said that surgery was certainly justified. And when they looked at the results and looked at the pathology, they found that only in 45% did the results meet these criteria, so that in 55%, the surgery was unindicated according to these 4 criteria. So again, if you looked at the surgical outcomes specifically for IPMN patients, and I sort of sorted this out because for me, it's the IPMN patients that are more difficult to decide what to do with. And you can see here that surgery was justified in the IPMN patients only about 50% of the time, and it was recommended against surgery a variable length of time. And if you look at specifically, if you look at the AGA guidelines, 12% of patients with high-grade dysplasia or malignancy would have been missed using the AGA guidelines, but 0 of those patients would have been missed by the Fukuoka guidelines or the European guidelines. So this is another study looking specifically at the Fukuoka guidelines, 194 patients. And again, the sensitivity, specificity, positive predictive value, and negative predictive value are shown here. This is juxtaposed to the same kind of criteria using the AGA guidelines, with the sensitivity and specificity of these guidelines for criteria for surgery being shown here. So the bottom line is that as much as we would like it not to be the case, this is really a situation where the clinician has to use imaging, whatever criteria else that they have, but they will not have a complete set of data, of reliable data, to make really accurate decisions. So all guidelines will be limited by our inability to fully and absolutely characterize the cysts. More must be known about the natural history, because some of these patients, even though they may have a worrisome feature, they never change over time, and we just don't have enough data to show that. And then you sort of have to choose your poison. Are you of the persuasion to send more patients to surgery to avoid any missing curable case of malignancy or near malignancy? Or are you less prone to send them to surgery and accept the fact that you will miss a chance for cure. Obviously, partly this depends on the quality of your surgeon. But again, you have to choose your poison. Are you going to send more people to surgery to make sure you don't miss a cancer, or you can send fewer patients to surgery and just accept the fact that there may be somebody that you miss, but you've saved the morbidity and mortality of surgery on those people who wouldn't benefit from it. And my final slide is this one, and I show it just because I think we're not there yet. These are the 3 made trials looking at endoscopic treatment cysts, but there are many, many issues that we have to resolve. We're not entirely successful at ablating cysts. It's difficult to know how to follow those patients. Will we be able to detect malignancy early on if it develops in cases where we didn't completely eradicate the cyst, et cetera, et cetera, et cetera. So my message to the audience is just that if you want to do a clinical trial, design it nicely and give us some answers that we need. But if you're just a clinician, I can't recommend treating patients with neoplastic cysts endoscopically. So with that, I'll conclude. These are my partners, and this is my new healthcare system. And again, beginning in 2022, I hope that you will have an opportunity to visit me in Orlando. It would be my great pleasure. So Roque and Paula and everybody, thank you very, very much.